My most intriguing research discovery at Penn came about in research I conducted for my capstone paper in Health and Societies. As a learner who's always been interested in the field of medicine and the messy relationship between science and humanity, I grew interested in how human rights advocacy is interpreted when it has direct links to health and well-being. In this pursuit to understand medicine's response to advocacy on a large scale, I decided to scour primary and secondary literature on the topic of domestic violence. My broad hope was to gain an understanding of the early history of domestic violence advocacy, called the battered women's movement, and determine how the medical establishment responded to a greater cultural recognition of wife abuse in the home. I sought to evaluate whether domestic violence may have been medicalized by turning being abused into a medical disease state, and determine how decisions made by activists may have influenced the medical response to the movement. The battered women's movement began in the 1970s, initiated by the pioneering work of Erin Pizzey in the United Kingdom. In 1971, Pizzey established the first women's advice centers in London, which eventually morphed into the first battered wives shelter and propelled her to publish her seminal text, Scream Quietly or the Neighbors Will Hear, which incited worldwide recognition of violence in the home as a reality for women around the world. Due to Pizzey's effective work sounding the alarm on battery, the battered women's movement reached the United States. The first battered women's shelter here was established in 1973, inspired by Pizzey's success in mixing a women helping women model within the battered women's shelters with very successful advocacy work. The first set of advocates in the American battered women's movement were largely uncompromisingly feminist, with many direct association to the larger women's liberation movement. They brandished signs stating that sexism kills and that we must stop men from controlling women. These pioneers saw the issue of wife battery as a consequence of a woman's powerless position in society. They called for reforms to the institution of marriage, which they saw as erasing a woman's identity and economic power, making abuse more socially acceptable and harder for women to escape from. Furthermore, they pointed to a lack of boys growing up with kind and vulnerable male role models as leading them to conform to masculine ideals of violence and aggression that would lead to battery when they grew into husbands. Thus, they saw the antidote to wife battery in the United States as largely relying on reforming unequal power between men and women in intimate relationships. This called for a restructuring of the American traditional family and gender roles, and challenging the old adage that the woman's place is in the home. The feminist activists that took charge in the battered women's movement were largely unified in their primary aims from the early to mid-1970s as the movement picked up steam. They aimed to thrust the private violence that was pervasive in women's lives out into the open, in hopes of inspiring societal change and empowering women to challenge patriarchal control. And they aimed to organize safe havens and support systems in the form of battered women's shelters for women victims to escape abusive circumstances. By the time 1977 rolled around, activists had forced the term battered women into the public consciousness. Americans could no longer feign ignorance about domestic violence. In opening these floodgates and succeeding on the advocacy front, the battered women's movement activists had to then cope with actually providing services to the countless women who they empowered to leave their circumstances by offering a safe haven in the form of shelters. The shelters, although short-term sanctuaries, were intended to offer solutions to the immediate factors that thwarted women and their children from escaping circumstances of abuse. These included food, money, employment, and social support. These services demanded many resources, and those resources came with a price tag. The shelters were incredibly costly to run and stressful to manage. As a consequence of these logistical challenges, women leaders of the movement began accepting financial support from and formed partnerships with professional organizations such as the federal government. As the scale of the shelters grew and as more women needed to be cared for, the battered women's shelters and counseling centers began to be run by people who were not necessarily steeped in feminist thought. By 1980, fewer than half of the existing battered women's shelters were founded by or directly related to feminist groups or ideologies. This openness to professional partnerships and interest in providing as much service to as many women as possible without feminist focus opened the movement up to partnerships with hospitals and the subsequent medicalization of battered women. Advocates for battered women called for an increased role of medical establishments in surveying for and helping to treat battered women. Healthcare providers were deemed by activists as neglectful of victims of wife abuse, often willfully accepting flimsy explanations for women's severe injuries in emergency departments, even in cases where battery by an intimate partner was undeniably evident. Activists in the movement called for hospitals to take responsibility for being on the front lines and called for people in the health field to study and classify the problem and prescribe preventative measures and treatment plans. Initially, in the early 80s, the response of the medical establishment to these calls by activists was to train nurses in better noticing signs of battery and offer women connections to legal avenues and women's services that were actually run by activists. Health practitioners were initially resistant to the notion of integrating detection and treatment of battered women into their own hospital care, largely due to a prevailing belief that such women were partly to blame for not leaving their circumstances. While physicians were largely hesitant to conduct medical surveillance and detect cases of battered women due to these personal biases and their own moral judgments, they were encouraged by administrators on high and department leaders to evaluate battered women within a symptom complex. This symptom complex was not only thought to be manifested physically, but also included the determination of a discernible psychological profile of a battered woman. The medical response to battery became more dominated by a victim profile of battered women, commonly called the battered woman syndrome. The battered woman syndrome was itself a construct pushed by activists at the time, most notably Lenore Walker. She crafted this victimization argument that was more focused on individual women than the broader patriarchal systems at play when it came to battery. This syndrome was an attempt to explain the condition of quote-unquote learned helplessness that was a consequence of the cycle of violence endured by victims of battery. It constructed a diagnosis of a battered woman who was broken and who was paralyzed by fear. This opened the door to the neat creation of a medical condition, which was then integrated into hospital protocols. This diagnosis made it easier for practitioners to conveniently categorize battered women as victims to be dealt with through a common downstream means, such as psychiatric counseling and prescription medication. Organizations such as the National Organization of Women had initially been calling for battered women to see themselves as not so helpless victims since the mid-1970s. Ultimately, the willingness to forge professional partnerships with hospitals and the federal government within the battered women's movement to help it grow, and the eventual construction of the quote-unquote battered women syndrome undermined the original feminist notion that addressing battery in society ought to center around addressing patriarchal systems of power, with greater focus on why it is that men were empowered to batter women in the first place. Instead, advocacy around domestic violence was derailed by work to frame individual female victims of these flawed patriarchal systems within a medicalized diagnostic framework that centers around their weakness and their helplessness.